Today we start some review topics related to MRCS Part A, and this topic is a topic related to uh, anatomy, especially dermatome and myotome and others. Okay, I just show you some of these. Okay. Okay, so welcome again and good evening. Today we start in some anatomy topics. As seen, it is common in our exam question part A. Again, anatomy is 75 question out of 300, and the most of the orthopedic question is related to anatomy. I see you can see now dermatome and the myotome. Dermatome and the myotome is very important topic in exam. You see the screen now or not?
Sorry, Prof. Can't see the screen.
Okay, I just try again.
Yeah, I can see it now.
Okay, so again, dermatome and the myotome is very important. Upper limb, lower limb. Many of the question in orthopedic and anatomy is related to dermatome and the myotome. Of course, if you come from upper shoulder, so C4, C5, C6, and it is important to know the thumb is C6, the rest of the hand is C7, little finger is C8, after that T1, T2, T3. Okay, so is the important or most of the question come in the hand? So again, the hand, thumb C6, the rest of the finger C7, little finger is C8. Okay, of course, it's the same in both sides. So this is very important. Dermatome is very important because they have the question like the patient have loss of sensation in the thumb, loss of sensation in the little toe. So it is important to know the dermatome for upper limb. Apart from dermatome, again, in the hand, you can find this area in yellow is innervated by ulnar. This is area in pink by radial. And the tip of the fingers, most of the fingers is by medial nerve, and they are overlap. This is overlap make the radial injury is an only a small area will be missed like this finger. If I see my hand here, so only this area, they have lots of sensation in case of the radial nerve injury because the overlap between the other nerves. Of course, innervation of the hand is very important. Again, usually the tip of fingers, except the little finger and the half of the ring finger, is supplied by medial nerve. Okay, apart from the thumb also. So it is important to know this innervation. So you can see even the thumb, it is half by median. So we can consider most of the finger except the little, especially the tip of finger is supplied by median nerve. Of course, median nerve can be injured or can be affected in carpal tunnel syndrome. Yeah, in exam you can find question like this. 45 years old woman presented with left arm pain, weakness due to prolapsed cervical disc. The pain radiated to middle finger. On examination, weakness in the elbow extension. Which nerve root is most likely to be affected? So in this question, so weakness, something in the cervical disc, middle finger. So if you go to the middle finger from here, you know simple that the middle finger is C7. So don't think much, don't looking for which nerve cause extension, which nerve cause flexion, all these. So just to show C7. So the blue here is the pain radiated to middle finger. And you know that from these dermatomes that all fingers except thumb and the little is C7. So just make it easy and make the question easier. So as you see here, so the answer is C7. Of course, we have something called the myotome, may be difficult to understand, but it is just to know that shoulder, for example, abduction, lateral rotation is C5, adduction and the middle rotation C6, 7, 8, flexion of the elbow C5, extension 7 and 8, forearm supinator is C6, pronator C7 and 8. Sometimes it may be difficult to remember all this number, so it is better to stuck to dermatome. Wrist only, in the wrist, flexion is C6, 7, extension C6, 7, so it is the same. Finger and thumb, again, flexion is C6 and 8, and extension 7 and 8 the same. Intrinsic muscle of the hand T1, I think we have a question about this. So intrinsic muscle or small muscle of the hand is by T1. Again, this is the dermatome, and again, it is in color, so you can see the thumb is C7, the most of the finger the thumb is C6, most of the finger C7, and the little finger is C8. Later, I think we come to the umbilicus, so it is T10. This is what happened if you have anterior interosseous nerve injury, what we called it Benedictine sign. So you can find the problem here. It is with interosseous nerve injury, and this is deformity or this flexion. And the patient can't do this movement, which is like okay, or just like this movement, he touches the thumb with the index. It is important to know musculocutaneous nerve supplies three muscles. Musculocutaneous nerve supply muscles, just remember BBC, like the radio BBC. So it supply biceps, brachialis, and coracobrachialis. Of course, motor flexion of the arm, elbow, supination of the forearm, and sensory. Again, musculocutaneous gives sensation to lateral surface of the forearm through the lateral antebrachial cutaneous nerve or lateral cutaneous nerve for forearm. So again, dermatome and dermatome in upper limb is important. It's common question, especially in orthopedic, and it is important just remember this page or these figures. I will send it to you to WhatsApp group. Okay, so it is easy. The same for lower limb. Lower limb is big, but you can start by L1, L2, L3 in the thigh. Of course, this area in patella is related to L3. After that, L4, 5, and S1. So you can see here, little toe is S1, and L4 for big toe. So it is important S1 and L4. Just remember the big toe and the little toe. So little toe S1, big toe L4. It's very important. The same of the back. And important, of course, to know the area around the anus is S2, 3, and 4. Of course, this is radiated to the back, so L2, S2, L4, and in the back, L4, 5, and S1, L4, 5. Of course, the anterior is more important because easy presented by the patient. Of course, myotome, again, you can just remember it is just adduction or medial rotation, L2, 4, abduction, lateral rotation, L4, 5. Innervation and eversion will come to later. It is inversion of the foot, L4, eversion, L5, and S1. Of course, in general, this is all muscle in general, started from diaphragm, phrenic by mainly S4. Of course, each nerve is not one root. It is like for phrenic is C3, 4, 5. But the main innervation is C4. C5 also deltoid abduction of the shoulder, and this is explain why the patient, if have acute cholecystitis, they have referred the pain to the right shoulder. C6 biceps and biceps jerk, C7 triceps and triceps jerk, C8 flexor digitorum profunda, extensor digitorum, T1 small muscle of the hand. So most of the small muscle or all small muscle of the hand is myotome is T1. T7 to 12 anterior abdominal muscle, L1 internal and transverso abdominis, So was major flexion of the hip L2, and it is important to know in the tendon is combined between iliacus and psoas. So iliopsoas tendon inserted in the risser trochanter, and iliacus supplied by femoral, and psoas supplied by L1 and 2. Quadriceps femoris and the knee jerk L3, tibialis anterior posterior inversion of the foot L4, L5 extensor hallucis longus extensor of greater toe. This is very important because many of the question say the patient unable to extend the greater toe. So unable to extend the greater toe is L5. So sometimes the patient have disc below L5 can be presented by unable to extend greater toe. C1 for ankle jerk, C2 for small muscle of the foot, and C3 perineal muscle, bladder, and are parasympathetic. Okay, it is important to know in the ankle or the foot we have two movement. We have ankle movement, which is flexion and extension, and we have inversion and eversion. So, for example, the ankle dorsiflexion L45, plantar flexion S12, ankle inversion L4, ankle eversion L5S1. And it is important to know the inversion eversion is metatarsal joint, but ankle dorsiflexion plantar flexion is the ankle joint itself. Of course, if you come up for the hip, it is L2 and 3 hip flexion, extension L5S1. So it is the same. Just remember, flexion is kick and bump, and extension is kickador to the back. Forget this, but just important, of course, to know that the movement in the ankle or the foot can be two movement, either ankle itself or mid-tarsal joint itself. So mid-tarsal is ankle inversion and eversion L4 and eversion L5 and S1. You can find some question like this. 25 years old man complain inability to evert the food after receiving a stab wound in the buttock. What is the most likely has been injured? Of course, uh, this movement inability to evert the food, so it is related to something of peroneal muscle, because inversions occur in the mid-tarsal joint again by peroneus muscle. Peroneus muscle or peroneal muscle, longus and brevis, is supplied by common, what's called a common peroneal. And because the patient has the trauma in the buttock, so it's most probably it is the common peroneal fiber component of sciatic, because sciatic is a big nerve and have some of component later become common peroneal nerve. And again, inversion is L4, eversion is L5 and S1. Very important and very common question. We can find some question like this. Middle-aged man involved in motor boat accident sustained separation of the lumbar spine from sacral. Of course, separation of lumbar from sacral mean L5 S1. Associating lumbar nerve root injury. Which is the following movement to be affected? So we're looking for something of L5. So we can go to back to see the L5. So L5 can be in the foot like L5 here. So it can be affected ankle dorsiflexion. So this patient following movement affected. So L5. So it is plantar flexion. Plantar flexion is S1. So they have the movement they have affected by S1. Foot inversion is L5. But so if it is L5, so it is foot inversion. If S1, it is plantar flexion. I think in the questions must be more accurate. You said it is the separation from, because usually the nerve roots down is the blow. So I think he means S1. So again, this is a movement of the knee, and this is a movement for the foot and mid-tarsal joint. Of course, reflexes and all this is very important. 21-old patient was stabbed in his upper forearm. On examination, while his palm on the table, he can't lift the thumb of the table. This is a tricky question because what he mean here, he means that this patient, suppose this is the table, this patient palm on the table, so like this, so palm on the table and unable to elevate the thumb. So this is movement is not flexion, it is extension. So this movement is extension because it is up like this. Okay. We show the movement of the thumb later. So again, this is the movement is extensor. And he asked on examination. So again, in this question, while the palm in the table, he can't lift the thumb off, means that extensor is affected. So the answer here is extensor pollicis longus tendon tear. Of course, extensor pollicis longus tear can affect the extension, but it is important to know the movement of the thumb. In the movement of the thumb, the easy way to remember, you just put the thumb in the hand in the anatomical position. This is the anatomical position like this. Okay? So this is like beside it, so it is adduction. To be abducted must be 90 degree like this. Okay? So if I put my hand here, so this is abduction. This is adduction. Because adduction like this, abduction must be 90 degree. So adduction, abduction. Okay? So you can see the movement here. Suppose you put your hand, we make it from lateral view. So it is abducted, it is adducted. Extension outside, flexion inside. Opponus, you count the finger. Adduction of the finger is different, it's just spanning or separated. Okay, so this is important to know the movement. Of course, all muscle of the hand, small muscle of the hand or small muscle of the thumb is supplied by median nerve. We have short muscle of the hand, adductor pollicis is supplied by ulnar nerve. Okay. So again, upper limb, lower limb, dermatome, mytome, very, very, very important topic. For anatomy, it is the same, also important in orthopedic. After that, we come to the dermatome in the abdomen. Dermatome in the abdomen is easy. Just look into the umbilicus is 10, T10, so 11, 12, L1. The same for the back. And for the question about the incision of inguinal hernia, usually incision of inguinal hernia is 1 inch, means that 2.5 centimeter above the inguinal ligament. So the incision is at the level of T12. Also the hernia in L1, but the incision in T12. If you need to make nerve block for the inguinal hernia, we're looking for 2 nerves, genital branch of genitofemoral, which is sensory, and ilioinguinal nerve, which in this area is sensory. Before that, in the abdomen, in the posterior abdominal wall, ilioinguinal have a motor fiber, supplies the conjoint tendon, and very rare if you have deep dissection in the abdomen and injury in the ilioinguinal main branch, so they can cause direct hernia because injury or weakness of the conjoint tendon. But what we injected in inguinal hernia is the sensory branch of ilioinguinal and genital branch of genitofemoral, which is sensory also. Again, this is T10 is the umbilicus level, and this is the inguinal region L1, but again the incision in the T12. One of the funny question in this innervation, they ask in some part about the tip of the nose. Of course, the tip of the nose is supplied by this tiny branch, nasal branch of the infraorbital nerve, tip of the nose. So the nasal branch or nasal nerve of the infraorbital, because just remember the orbit here, so it is infraorbital nerve. It is come, but it is very rare to remember, so this is why I put this picture. You can find maybe here the tip some branches infraorbital here. This is the infraorbital, so they have a nasal branch. Okay. Of course, relation of the first rib surgically is not important, except, of course, you know that in the central line you injected or you put something in the cannula in the vein, the artery is more deep. So they have the subclavian vein, subclavian artery. What is important nowadays is sympathetic chain. This sympathetic chain in yellow. So this sympathetic chain, now we have a common operation called thoracoscopic sympathectomy for hyperhidrosis. Hyperhidrosis means the excessive sweating in the hand in some people. So they go to the surgery and they have cutting of the sympathetic chain must done below the stellate ganglia. Because if you did it at the level or above the stellate ganglia, the patient have Horner syndrome, which is anhidrosis, meiosis, and enophthalmos. Of course, it is easy. Stellate ganglia is big and usually go to the thorax, so you don't reach the first lip level. You must be down. But what happened sometimes, because you use diathermy, so can be migrating the electrical current and can damage the stellate ganglia. So nowadays it is better to just put two clips and cut between the clips. Of course, you don't able to reach the first rib, so you come down. So usually you are in the level of the second, third ribs or between third and fourth, so it is easy to cut sympathetic chain. Okay. Of course, most of the question nowadays about this sympathetic ganglion injury or thoracoscopic sympathectomy. Thoracoscope like laparoscope in the abdomen, and thoracoscope in the chest, thoracic cavity. Of course, this file is about dermatome and myotome. The second important file, maybe for some student is headache, is the spinal cord injury, especially what we called it incomplete spinal cord injury. Okay. Of course, you can see the screen now.
Yes, Prof
Okay.
can see.
Okay, all right. Usually, theoretical, we don't. It is difficult to have an incomplete spinal cord injury simply because during transportation, incomplete become complete. But what happened usually if the patient have a small tumor, especially benign tumor like meningioma, so can be incomplete pressure or complete damage for spinal cord. Of course, we have the common question about Brown-Sequard syndrome. You can find something like this. 22 years man is shot in the back. In the lumbar region, he is increased tone hyperflexion in his right leg. He can't feel left leg. So in the same site of the injury, they have motor dysfunction or motor paralysis. In the other side, have loss of sensation. This is what we call it Brown-Sequard syndrome. Can be incomplete injury, can be due small bullet, can be due to meningioma. Of course, even bullet, because the bullet cause like damage around it, not the size of the bullet, because it is a heat and damage, so it usually make a complete. But just to know that in Brown-Sequard syndrome, they have paralysis in the same site, loss of perceptions and fine discrimination in the same site, and the pain temperature contralateral site. Okay, so ipsilateral paralysis means motor paralysis. Proprioception and fine discrimination may be difficult to be noticed by the patient, but contralateral loss of pain. So you can find the same famous question, 58-old woman known to be thoracic right-sided meningioma. Meningioma is a benign tumor, but you know benign tumor in a small area can compress and cause damage, like pituitary adenoma, affect optic asthma, caused by temporal hemanopia. Okay. Presented with a feature suggests Brown-Sequard syndrome. The clinical finding will include which of the following? So this patient have right side. So we're looking for weakness, left side. So either A or E. Left side weakness, left side perceptions, fibrillation. Right side loss, bang, break sensation. Okay, we go to the E, left side. So, okay, so this patient have right side. So right side paralysis and weakness in the left side. So the answer is B. 27 years old man presented to emergency department after being stabbed in his back. He is now unable to move his right leg, so right side. Examination noticed that he can't feel pain in the left leg. Also, motor function in this limb, in the left mean, preserved. So it means that this patient, right side paralysis, left side loss of sensation. So it is a typical of Brown-Sequard syndrome. This is a common question and easy, and sometimes come in the surgery under neurosurgery. Okay, apart from this, if you see the spinal cord, you have a lot of lesions like dorsal, spinothalamic, central, and function of spinal cord. So it is different. What is important to us? Some very important, the other is not important. So for example, we show you something called syringomyelia. Syringomyelia is selectively active spinothalamic tract. So if you go to spinothalamic tract, so you can find loss of pain, sensation, and temperature. So this patient, no motor losses. So the motor power is okay, but no pain, no sensation, no temperature. So this patient, for example, is easy to have a burn. It's easy to hurt himself because have no sensation. For example, in this scenario, 68 years old man presented to the plastic team with severe burn in his hand. So have a burn in hand. He's not distressed by the burn, so no sensation. He has bilateral Charcot joint. Charcot joint means that the joint can move in the all direction or the reverse direction. On examination, loss of pain, temperature, sensation in upper limb. So loss of sensation, pain, sensation, and temperature in upper limb is a spinothalamic tract, something called syringomyelia. So affect spinothalamic tract. Syringomyelia in Latin means cystic cavity. It is can be variation of error the Chiari malformation. Error the Chiari is hydrocele and sometimes have meningocele. Can occur in some cases after meningitis or after surgery or after tumor. Again, pain, temperature is losses. Bilateral distribution, so can be in both upper limb. And if you see the picture here, you can find it is something central. So it is in the central area which affects the sensation. So this is what we called it syringomyelia or spinothalamic tract lesion. I think I have a picture down. No, this parent is spinothalamic. No. Okay. After that, the second lesion, of course, so again, the first lesion, Brown-Sequard, is just paralysis in one side and the loss of sensation other side. If the patient have a spinothalamic tract or syringomyelia, so they have loss of sensation, but the motor function is okay, common in upper limb. Sometimes a very rare anterior cord syndrome, anterior two-thirds of the spinal cord, so they have motor paralysis below the level of the lesion, bilateral. So here is bilateral. Loss of pain, temperature at and below the level. So in this patient, like complete dissection of the spinal cord, so they have motor paralysis below the lesion, bilateral, and also loss of pain and temperature. It is occurs sometimes in infection, something called transverse, what's called transverse myelitis, some viral infection. It is medical disease, so it's not worry. Can occur in severe cases of disc prolapse, tumor, compression, and occur also in the cervical flexion, what is called decerebration acceleration trauma. So if you see these patients, you can find, suppose the level is here, so they have loss of motor, pain, sensation, vibration, touch, all these below the level. So this is what we called anterior cord syndrome. Central cord syndrome, again, it is a syringomyelia, so it is occur also in older age, cervical spine disease, cervical spondylosis, so it is the same. Some weakness in the arm, upper limb is more affected, but preserve motor and sensory fiber. So they have a motor, but sensation is intact. So this is what we call the central cord syndrome. It's occur in cervical spine disease. It's not common. Posterior cord syndrome, posterior cord responsible for proprioception and hyperextension injury. So loss of vibration, ataxic gait, positive Romberg sign. Positive Romberg signs, it is like alternative movement and hypotonia and ablation of the deep tendon reflex. This is posterior cord syndrome, is very rare. So this is a normal spine cord. This is if you have something anterior, posterior in the back. So again, anterior, loss of the motor and sensation, as we mentioned before. Central, so you can have some sensory sparing, but motor fiber involvement. Brown sequard, which is important to us, incomplete, so loss of the motor function in one side, and contralateral, they have pain, temperature, sensation. If you see the question coming previous exam, 76 years old man presented emergency after fall, and he's now feel weak in his arm and leg. So weakness in the arm and the leg. So motor power. On examination, weakness in both arm and the motor weakness of the leg, unable to feel pain in the leg. So this is anterior cord syndrome. So it is like complete injury of spinal cord. Of course, different from level to level. 67 years old woman with guarding at home when she developed sudden onset of lower backache. She found difficult to get back in the house. Before she called an ambulance, she is now pain in both leg, unable to pass urine. On examination, reduced sensation around the perineum was most likely diagnosis. This patient just reduced sensation around perineum, but she can walk. She has some weakness, but she can walk. This is what we called it coda equina. Coda equina is like caudal anesthesia. Now we have something called caudal anesthesia. Caudal anesthesia, you can anesthetize only the perineum, and the patient can walk after surgery. It is not like a spinal anesthesia, which is affected the both lower limb, motor, and sensation. I think this is the last question. 68 years old man presented plastic team. Again, is burn in hand, is not distress the burn, bilateral Charcot joint. I think this is repeated, and this is syringomyelia. Okay, so what is important to us is just syringomyelia, because can come with patient with burn, and Brown sequard syndrome, which is a semi-incomplete or incomplete affection of the spinal cord. Of course, the anterior cord is have paralysis, loss of pain and temperature, so it is easy to be diagnosed. Of course, usually you have one or two questions in this, and usually the question come in the Brown sequard syndrome. The last topic is important also to us is embryology. Of course, embryology in exam, we have 5 questions in embryology. But usually it is important to know If I need to ask you in embryology, I ask you in thyroid, I ask you in the diaphragm, I ask you in the pharyngeal arches and pharyngeal pouch, because this is the commonest to be asked in the exam. So it is important to know these topics. All this file I send it to WhatsApp group, so it will be easy to review it. It is important to review it if you enter exam in January, to just review it before the exam, the week before the exam, because it is very important. What is the important topic in embryology? Of course, pharyngeal arches or arterial arches, diaphragm, development of the heart, thyroid, parathyroid, some related to kidney, axis of rotation of the gut, and the cleft lip, cleft palate. Okay. Of course, we don't have much detail, but pharyngeal arches must be known by the heart, especially nerve for first arch, mandibular nerve, second facial nerve, third glossopharyngeal nerve, fourth to sixth recurrent and superior laryngeal. And it is important if you go to the first, mandibular nerve, skeletal structure like uncus, malleolus, muscle of mastication, mylohyoid, anterior belly of the gastric, tensor tympani, tensor palatine, and the sphenomandibular ligament, and the anterior ligament of malleolus. The second important and common question is second arch, because it is supplied by fascial. It is important to know as a bone, so the usual fascial supply stapes, styloid process, upper part of hyoid bone, lesser cornea of hyoid. But for the innervation, it is important to know that the fascial supply all muscle of the faces. So all muscle of the face is supplied by fascial. Posterior belly of the gastric supplied by fascial. Stapedius muscle in the ear supplied by fascial. Styrohyoid muscle supplied by fascial. It is important in this topics to know that the styloid process, although it is single tiny bone, have three muscle attached. Stylohyoid supplied by fascial, stylopharyngeus supplied by glossopharyngeus, and styloglossus supplied by hypoglossus. So three muscle attached to one bone. Each muscle have different blood supply. Okay. So again, facial nerve is very important. Facial expression, including platysma, of course, posterior belly of the gastric, stylohyoid, stapedius muscle, and the ligament is stylohyoid. Third, glossopharyngeus. It is important to know glossopharyngeus supply only one muscle, which is stylopharyngeus. And it is, as mentioned before, it is one of the three muscles attached to the styloid process. Again, one of them is stylohyoid, which is supplied by fascial. Second is stylopharyngeus supplied by glossopharyngeal. Third is styloglossus supplied by hypoglossus. Fourth to sixth, recurrent laryngeal nerve, and give the muscle of the pharynx, larynx, and the palate, and give skeletal like thyroid cartilage, arytenoid cartilage, and other cartilage. Okay. It is important to know embryological origin of stapes, second pharyngeal arch, because the first arch, Eustachian tube, middle ear, mastoid antrum. Second tonsillar fossa. Third, thymus, inferior parathyroid gland, and the fourth, superior parathyroid and the part of the thyroid. So this is important because in some anomalies, if we found thymus is absent, so the inferior parathyroid is absent. It is important to know, although the inferior is lower, but it is origin from the third arch or third embryonic origin, and the fourth gives the superior. So the lower by third, the fourth is by fifth. By fourth. So the 3 is down and 4 is up. And it's important to know in anomalies or embryological maldevelopment, if you don't have a thymus, possibly you don't have inferior parathyroid. So the question like this, from previous exam question, what is the nervous supply of the second branchial arch, so the answer automatic will be fascial nerve. After that, we have some source called aortic arches. Aortic arches like this, not the arch of aorta. Okay, so it is just to differentiate. So this is the aortic arches or pharyngeal arch arteries. It is six-paired embryological vascular structure. It is easy to remember. First, maxillary. Second, stapedius and disappear later. So disappear. Third, common carotid. Fourth, arch of aorta right subclavian. Fifth, disappear. So you have second, fifth, disappear. Sixth, pulmonary arteries, ductus arteriosus. What is common in exam? They ask you about pulmonary arteries, right and left, or ductus arteriosus. The origin from six aortic arches. Aortic arch mean pharyngeal arch arteries, is not arch of aorta. Of course, as you see here in the arch of aorta, we have brachiocephalic, we have common carotid from the third, left subclavian, but pulmonary arteries arise from the sixth. Okay, this is just remember it may be complicated, but it is the arches, what happened to the arch. Sometimes just say six is like a lung, so it is six arches. And this is a common question, I think. Usually very common question, come each exam, they ask you about the origin of the right left pulmonary artery or the origin of ductus arteriosus, which is communication between the aorta and the pulmonary artery. So the answer is the sixth aortic arch. Very common question, come maybe every exam. The second or the third important topic is the development of diaphragm. As you see, the diaphragm is big muscle. They have big area called transverse septum and right and left pleuroperitoneal fold. Of course, they have holes for inferior vena cava, for esophagus, for aorta. So usually in transverse septum is difficult to have anomalies, and this area is occupied by heart. But what happened usually either right and left. The right side, even if you have defect, because the liver is a big organ and obstructs the area, so most of the anomalies appear in the left side because the stomach, the colon, the intestine can be easy to jump in the chest wall or in the thoracic cavity. So again, from a biological point of view, diaphragm is developed from four parts. Septum transversalum becomes central tendon, very rare to have a hernia inside it. Dorsal esophagus mesentery, peripheral limb, and the pleuroperitoneal membrane. And the pleuroperitoneal membrane is usually the site of that. Apart from innervation of diaphragm, it is C3, 4, and 5. Because the diaphragm is originally developed in the neck and extended down, so this is explain why he take it from the phrenic. It is important to know just to mimic. We have two congenital diaphragmatic hernia. Of course, we paraesophageal can be mixed, can be sliding, which is can be in adult. But in baby, we have two hernia, something called bogdalic. Just remember, it is P for posterior and B for bogdalic. And anterior is called, or medial is called Morgagni. So MM, so it is median and anterior, and bogdalic is posterior. Of course, the hiatus hernia is easy. So Morgagni congenital, it is 3% defect in the anterior part of the diaphragm, usually in the middle. But bogdalic, both are name of persons, result in failure of posterolateral, so it is posterior. Okay, so if you mention this patient have hernia anterior, of course neonates, so it is Morgagni, posterior, so it is bogdalic hernia. It's very common in pediatric question, pediatric come in paper too. After that, in embryology, which is important to us, is the fetal circulation. So it is important to know because the lung is not much function in the baby. So usually you have a connection between right side and the left side of the heart through foramen ovale. Or what if defect continuous, we called it atrial septal defect. And you have a connections between the arch of aorta and the pulmonary artery and the arch of aorta, and this is called ductus arteriosus. Can be patent ductus arteriosus later. And of course, we have here, after cutting the placenta, so all these arteries become a ligament, like a middle umbilical ligament. So this is extra because I just to differentiate between median and medial. Of course, median umbilical ligament is urachus. Urachus is a connection between urinary bladder and umbilicus. So apex of the bladder to umbilicus. This is explain why sometimes the baby can have urine come out from umbilicus. This is beta urachus. Urachus, if you have a tumor, can cause adenocarcinoma. It is rare tumor, and it is the only adenocarcinoma can appear in urinary bladder. This is not related to our discussion about fetal circulation, but just to differentiate between median and the medial. Medial is the umbilical artery. So if you come down, the umbilical arteries, so after an adult become medial umbilical ligament. So the artery become medial umbilical ligament. Lateral is covering four inferior epigastric vessels. Umbilical vein become ligament of trees in the liver. You can see in adult liver. Of course, obturator ductus venosum become ductus venosum. Ligamentum arteriosus become ductus arteriosus. Foramen ovale become foramen ovale. Okay. Again, foramen ovale is a connection between right and left atrium, so can be patent, so can be atrial septal defect or ASD. Ductus arteriosus can connect the aorta pulmonary, so can be patent ductus arteriosus. And the others is usually obliterated. So they can found question like this. Remnant of urachus, it is median, not medial umbilical ligament. Child with patent ductus arteriosus, left sternum murmur heard in the chest. What about this anomaly? It shunt to pulmonary artery. So this is ductus arteriosus. You can see here, patent ductus arteriosus, shunt between the pulmonary and arch of aorta. Patent ductus arteriosus. Okay. In fetal circulation, how the blood pass to the right to the left atrium. Of course, they have opening because the blood don't go to the pulmonary circulation. So it is foramen ovale. After clamping umbilical cord, what will not give oxygenation blood to the embryo anywhere? So clamping of umbilical cord, so you close ductus venosum, so it is become closed or ductum venosum. So again, it's easy just to know some anomalies. The common exam is patent ductus arteriosus with specific murmur, and he asks you some related to the circulation. Another anomalies you can see, it is phallotetralogy. Tetralogy mean four. So the patient have ventricular septal defect, pulmonary valve stenosis, pulmonary artery stenosis, misplaced aorta, thickness, right ventricular hypertrophy. So this is the typical of the phallot. If this not typical, so they give you something, what we called it, interposition of big arteries. Or like this question, 2-day-old baby presented with increased respiratory distress, born at full term by normal vaginal delivery. On examination, they have cyanosis of the lower limb. Marked respiratory is drawing to the chest. Femoral pulse is absent bilateral. Has anuria, so kidney is affected in the last 2 hours. Pulse rate 140. Regular blood pressure is low, 60/30. Equal in upper limb. So equal because to differentiate between coarctation of aorta in some patients. So this is, if you see here, not mention pulmonary stenosis, no pulmonary valve stenosis. If we don't mention pulmonary valve stenosis, so we called it interrupted aortic arch. If they have pulmonary stenosis, we called it complete or fallot tetralogy or F4. So it is just a little differentiation between fallot tetralogy and abnormal aortic arch or interrupted aortic arch. Second question, in fetal circulation, most of blood passing from the inferior vena cava into right atrium, subsequent pass next to, of course, right atrium. Don't go to the right ventricle and go to pulmonary circulation. He went direct to left atrium. After clamping, I think the same umbilical cord, not give oxygenation to the embryo anywhere, so the after clamping it become ductus venosus. So again, fetal circulation is important. The very, very, very important topic for us is the thyroid, because thyroid is a common surgery done in general anesthesia. And again, in this exam, we have a lot of it is also including MRCS for ENT. What I need to explain, what is new now, of course, thyroid gland is endodermal structure. Thickness that form the verticulum of the medial surface develop pharyngeal floor. It is between the first and second pharyngeal pouch. Develop from tubercle impar and foramen cecum. Foramen cecum in the tongue. So it is developed in the foramen cecum of the tongue and descend down. So become up and descend down. This is explain thyroglossal cyst or failure to descend of the thyroid. So migrated caudally, anterior, sometimes the posterior, sometimes within the hyoid bone, and this is explained during thyroglossal cyst surgery. During thyroglossal cyst surgery, you need to cut the middle of hyoid bone because sometimes the tract above or below or within the hyoid bone, because it is due to these anomalies. After that, migrate caudally. Okay. What I need to add it here, of course, we mentioned thyroid is endoderm. What is the new parathyroid, parafollicular cell? Derived from neural crest, secrete hormone, what is called calcitonin. And this is explained medullary thyroid carcinoma occur in parafollicular cell, which is from neural crest and secrete calcitonin. Okay. Till the last few years, till I think this paper is in till 2015, till the last 10 years, we consider this parafollicular cell as ectodermal cell. But nowadays or recently, not much recent, they consider as endoderm, not ectoderm. And this is the reference paper if you are interested. Okay. So nowadays, both the thyroid gland totally, so we can now consider the whole thyroid and parafollicular cell, both are endoderm. If we have all the book, they consider the thyroid is endoderm and parafollicular cell, which secrete calcitonin, is neuroectoderm. But nowadays, or in the last 10 years, they consider as both as endoderm, so no ectoderm at all. We don't ask you this detail in exam, but the important to know for our exam is to know that the parafollicular cell secrete calcitonin and they can cause medullary thyroid carcinoma, and the medullary thyroid carcinoma can be part of the multiple endocrine neoplasm type 2. Okay. This is the descent of the thyroid from the foramen cecum, tongue, so up above or below or beside hyoid bone and come descended down. Failure of the descent of it, we called it thyroglossal cyst. It is important if the patient have thyroglossal cyst to don't remove thyroglossal cyst except to confirm this patient have a thyroid gland, because what happened, you can remove the thyroglossal cyst and the patient become have no thyroid at all because it is the only thyroid tissue and no thyroid gland. So it is important before thyroglossal cyst to confirm the patient have a thyroid gland. If it's the only thyroid tissue, no need to remove. So this is again the descent of the thyroid. Okay, is again can be related to hyoid bone, so you need to cut the middle. Again, parathyroid gland, as we mentioned, it is endoderm, third and the fourth, and again the superior is from the fourth, so from 4, and the inferior from the third. Is very basic knowledge, just come in exam. Again, in exam, we have few question, maximum 5 question in embryology. The second or common question, so the common question ask about pharyngeal arches or ask about the thyroid and the parathyroid, and the commonest also is cleft palate and the cleft lip. Of course, this is cleft lip. And cleft palate is above. Something here. So it is just to know the easy way. The cleft palate is defect in development of primary plate. Not shelf, not palatine shelf. So it is defect or failure of development of primary plate. So it's something in this plate, which in the future we called it hard palate, can cause cleft palate. So cleft palate is a failure in this area. In the future we called it hard palate. So cleft palate is hard palate only, and it is failure development of the primary plate. But cleft lip is failure to fusion of maxillary process and the medial nasal process. So this is area in embryology, we called it maxilla, related to maxilla and the medial nasal process. So this is a cleft lip. So again, cleft palate, failure development primary palate, or if they ask defect in the fusion of the plate process, because the cleft lip, cleft palate in the hard palate. So it is in the hard area. So it is primary plate and palatal process. But cleft lip is a failure of maxillary and the medial nasal process. So they have this. Can be unilateral, can be bilateral, can be incomplete, can be partial, and they have it is just in the skin, subcutaneous, and the mucosa, not affected the hard palate. So can be unilateral, can be bilateral, and this is normal. Okay. So again, we have cleft lip, cleft palate, and very common question in exam. The last anomalies we can have in the exam is what we call the hypospadias and epispadias. It is just too important to know. It is like the food. So suppose this is a penis. Suppose this is a penis. So if the defect is up here, we called it epispadias. If low, we called it hypo. And this surface, we called it dorsal, like the dorsum of the food. And this is, we called it ventral. So this is dorsum, this is ventral. This is epispadias, this is hypospadias. Okay. We have two anomalies. So if you have hypospadias, you can have cryptorchidism. If you have epispadias, you can have loss of the anterior wall of the abdomen defect and related to urinary bladder, what we called it ectopia vesica. So, infant found to have slit-like opening on the dorsum aspect of the penis. So it is upper part of penis, this area. So it is epispadias. So the associating congenital problem is extrophy of the bladder, means that loss of the area of the bladder. And of course, anterior abdominal wall. But if the patient have hypospadias, they maybe have cryptorchidism. And again, hypospadias is the ventral aspect of penis. So again, you can see the picture here. If it is down, so it is hypo, ventral surface. If it is up, dorsal surface, we called it epispadias. So again, just to remember, if this is a penis, dorsal, epispadias, down, hypospadias. Of course, the common is hypospadias. But if you found defect in the anterior abdominal wall, bladder is appear, so most probably this patient have epispadias. The last question usually come in exam in GIT anomalies. It is the last anomalies we have. So what we can have, which of the following serves as axis of gut rotation during development? Of course, the rotation of the gut, and this can cause malrotation or twisted, or all these can occur in the axis is superior mesenteric artery. Second question, and very common, they ask you, you know that pancreas is two part, ventral and dorsal, united together at the area of the duodenum as the second part of duodenum. So if they still at present, we called it annular pancreas. Is rare congenital anomaly, a ring of pancreatic tissue surrounding descending portion of duodenum, what we called it second part of duodenum. So it is incomplete rotation of ventral pancreatic bud. The pancreas is too bad, and failure to rotation to become medial in the curvature of duodenum, we called it annular pancreas, is very common question. The patient can present it by obstruction of the duodenum. Of course, again, one of the common causes to differentiate between this patient have hypertrophic pyloric stenosis or something in the duodenum or second part or the small intestine. Usually in the hypertrophic pyloric stenosis, the vomiting from the patient is contained no bile, is not no bile at all, so it is hypertrophic pyloric stenosis of the stomach. But if they contain bile, so it is something in the intestine. Of course, annular pancreas is very common question. You can see this question, for example, 3-year-old boy admitted to hospital with severe vomiting, radiological examination, refer that suffering from annular pancreas. So what is structure constrict is the second part of duodenum. So of course, you know duodenum is one, first, second, third, four part. So this is the second part of duodenum. The other anomalies you can found this is in the anus and urogenital. So sometimes you can find defect here, incomplete septum. So this is what we called it cloaca. So the abnormal development between urinary bladder and rectum. So a newborn baby girl pass meconium via vagina, and after examination show lower vagina. What is the embryological origin? This is improper division of cloaca septum. So cloaca septum is separated between urinary bladder or uterine part and anus. If it is present, so it is like this. Urogenital sinus can be urinary bladder, can be urinary bladder and uterus later, and the rectum, so are separated. If not separated, so we called it improper division of cloaca septum. Okay, this is not common, but just ask you for the anomalies. So again, I send you this all to the WhatsApp group. So this is the important topic you need to study in embryology. No much than that, just in simple way. And some of them come in anatomy. Some of these topics come in the specific like urinary or other origin. Okay. The last topic for today, because last time we speak about ASICS and some statistics and ECG and physiology, but the last topic for today is orthopedic. Of course, orthopedic is a big topic in the second part and also in some anatomy question. And again, if you have good knowledge in anatomy, it is easy to know orthopedic. But some fractures have some funny name, so I just collect the names just for revision. We don't ask the name specific, but if just to say it is Cool's fracture or something, you need to know what is this, at least which part. Okay. I just go through it simple way. Okay, I just put some X-ray. In exam, sometimes you have X-ray, sometimes you don't have X-ray. But usually nowadays, because it is online exam, so we have an X-ray. Of course, the common fractures. You can see the screen now, by the way. Anyone?
Yes, Prof.
Yes, okay. So the common is Cool's fracture. In some books, they called it like dinner fork, like this deformity. Of course, Cool's fracture is as any fracture in upper limb is full of outstretched hand. So in scaphoid fracture, the same. In Cool's fracture, the same. Many type, but it is at least fracture radius, proximal to radiocarpal joint, and dorsal displacement and angulation. So the patient have some angulation, dorsal displacement, and it is transverse fracture of the radius. So this is Cool's fracture. Reverse of Cool's, which is not important, is Smith fracture. Angulation of distal radius fragment causing by falling back on the palm of the outstretched hand. So it is Smith fracture is reverse of colon is not common. Bennett fracture is fracture of the first carbo-metacarpal joint. This one. First carbo-metacarpal in this area. Impact of the flexed metacarpal caused by fist fight. Of course, they have just a triangle fragment in the ulnar base of the metacarpal. Just little fracture. Montogia fracture is a dislocation of proximal radio ulnar joint with ulnar fracture. So they have fracture of the ulna and displaced of it. Of course, fall on an outstretched hand, forced pronation, need prompt diagnosis to avoid disability. So it is a fracture and joint dislocation. These fractures with dislocation here, we called it Galezzini. Of course, it is not important to know all this name, but just the common. It is radial shaft fracture with dislocation of distal radioulnar fracture. So distal fracture here and dislocation here. So distal fracture of the radius and dislocation. Of course, it's the same, full of outstretched hand. On examination, they have bruising, swelling, and all this, and X-ray is diagnostic. So this is fracture and dislocation. Distal radius fracture can be associating with radiocarpal dislocation. So the dislocation of some of the carpal bone, we called it Barton fracture. Not important. The important is scaphoid fracture. The scaphoid fracture is a common. Of course, because of the pattern of the blood supply of the scaphoid, it is come distally and it is common question in the anatomy. Of course, it is forms the floor of anatomical snuff box, and the boundaries of anatomical snuff box is important. This fracture is associating or can be have the risk of avascular necrosis. Movement in it is difficult, but you can find if you press in the anatomical snuff box, you can find some tender. In the early case or at time of fracture, you don't see something in the X-ray, but later you can see the fracture. In some center, in some country, they do radioactive isotope to exclude the scaphoid fracture as early as possible. So again, it is commonest. Follow out stretched hand. They have blood supply is special pattern from distal. It is floor of anatomical snuff box. It is they have tender in the anatomical snuff box. Maybe some under deviation, and they have special plasters to do for this. So this is as regards the upper limb. Well, lower limb, of course, we have both fractures, which is tibia and fibula. We have tibia and fibula, and it is the common fractures, bimalleolar ankle fracture. We have fracture neck femur. Fracture neck femur have many grades. Not important to know the grades, but it is important to know in the higher level can be have avascular necrosis, and we need to make hemoarthroplasty or removal of this part. But it is important in young people because this is joint or hemoarthroplasty can be due to wear and tear. So after 10 years or 15 years nowadays, you need to be changes. So usually in young people, it is better to start by plate and screw just to see the result. So you can find this question, for example, middle-aged man with subcapital femoral neck fracture with minimal displacement. So this is young, not old, so they can do internal fixation with a nail. But if this patient is old, it's better to do hemoarthroplasty and remove the whole head and put artificial one. So this is what we did in the young people. So internal fixation with a nail. Can be nail, can be something like this. So they have different. Okay. Of course, fracture neck femur is important because of the vascular necrosis. Blood supply of the neck of femur is important. In baby, it's come from ligament teres, and in adult is through retinicular blood supply. We have something very not common, but it is inflammation in the patellar region. This area, especially at the end of the quadriceps femoris, they have a bursa here, patellas here, and they inserted in tibial tuberosity. We called it Osgood-Schlatter disease. Osgood-Schlatter disease is a condition caused by pain, swelling below the knee joint. This is usually patellar tendon. So it is patellar tendon. Patellar tendon is a continuation of the quadriceps femoris. May be inflamed. Don't cause, it is not serious, but sometimes can produce lump due to excessive bone growth, so become cosmetic, and the patient asks for excision of this lump. It is just inflammation or irritation of the quadriceps tendon inserted here in tibial tuberosity. Okay. We back to fracture tibia and fibula. We have a lot of debate, but usually if you find the small segment like this, so it is better to fix it because plaster can, this long segment, just short segment, so plaster cannot work. So 25-old female displaced the fracture tibia fibula 2 cm from the ankle, so short segment. So the better management is fixation by plate and screw. This is, we can leave it, no problem. But this is better to have plate and screw. This is also can have plate and screw. Of course, in any separation of the joint, you must have fixation. The ankle fracture is not important to know. The second topic in pediatric is very, very, very common in exam, and you must have the three questions follow each other about Bersa's disease, about transverse synovitis, about SUFI or slipped upper femoral epiphysis. So I just make a comparison between the Bersa's, SUFI, and congenital dysplasia, just to be easy. It is important to know nowadays we have ultrasound for the joint, so you can choose the joint we show you now. We start by Bersa's disease. It is avascular necrosis, femoral epiphysis of the femoral head, impaired blood supply to femoral head, causing bone infuncture, new vessel developed, and ossification occur. The bone either healed or subcondylar fracture occur. Of course, it is occur between age 2 and 12. So young, can be bilateral, diagnosed by X-ray or technician bone scan. So this Perses disease. It is some sort of avascular necrosis without any cause. Okay, so this is Perses disease, bone death. Transverse synovitis is easy. Viral illness, high white blood cells, or C-reactive protein or ESR. So patient have fever. So it is transient synovitis. So it is easy to diagnose from the history. It is important to know that we have ultrasound for the joint. We can diagnose some disease like effusion and can take a sample guided by ultrasound. Of course, a sample taken for culture and sensitivity. SOFI or slipped upper femoral epiphysis, common in obese or overweight adolescent male, so it is over age of 12. So if younger, can be Perses disease. If the older, little older, can be overweight, can be slipped upper femoral epiphysis, something like this. Of course, X-ray can appear, and treatment usually with rest and non-weight bearing creatures. This is just, you can read it, I send it to you. So presentation, treatment, and radiology. So 12 years old boy presents the clinic with knee pain. On examination, when the doctor flexes the knee, there is external rotation, which most likely cause. It is important first to know any hip pain referred to the knee, any knee pain referred to the hip, because the innervation is both. So if the patient have knee problem, he have hip pain problem, hip joint problem, if have hip joint problem, so they can have knee also. This is a little old, but they don't mention that overweight. He must mention overweight, and this is slipped upper femoral epiphysis. So it is occur after 12 to 16. Can be in girl, can be in boy, and of course no fever, so it is not transverse synovitis. 6 years, so young, brought to his mother after notice he has evidence limping with pain left hip. She denied history of trauma, so no trauma, no fever, no leukocytosis. So what is the most likely diagnosis? So the most likely diagnosis is Perses disease. Again, Perses disease occurs till age of the 12, can be from 5 to 10. Okay, after that, we have some tumor can appear in X-ray, like this is onion-shaped tumor. So, man presented with the right leg fracture, onion peel appearance, was referred in the X-ray. What is your diagnosis? Of course, usually nowadays, we don't look into the X-ray. You can have CT, you can have other, but still X-ray is important in orthopedic practice. And this is funny just because it is common. So onion peel, So it is Ewing sarcoma. Ewing sarcoma occurs sometimes after Paget disease. Of course, occur in adult. Some funny question like mechanism of trauma. Mechanism of trauma like 70 years woman suffer from multiple metastatic bone lesion, sustain a fracture through the metastatic lesion in her humerus when her dog pull on her hand. If you see in the mechanism of trauma is different. We have, for example, if say in the scenario, the patient have, suppose this is a bone, and the patient have direct trauma by the car. So usually it is transverse fracture. So transverse fracture, it is direct trauma. If you have direct trauma in your hand, so this is cut, so the transverse fracture. If you have twisted fracture, so can be oblique. So you can see the mechanism of fracture here. Direct trauma, transverse. Can be oblique if you have some rotation. If big trauma can be butterfly. But in a spiral injury like this. So although this mechanism, he need to mention that this patient have very weak bone because have metastasis. And her dog pull on her hand. So it is like oblique trauma, like pulling, like this movement. So it is oblique, like rotatory movement. So it is oblique. Okay. So you can find here oblique trauma occur when a force apply at any angle other than the right angle. So right angle transverse. Oblique trauma or one angle can be oblique fracture. A spiral fracture, if you have twisted, so can cause a spiral fracture. Okay, of course, a fragment is heavy trauma or high velocity trauma. Of course, this is just for fun, but it is metastatic, pulling in one side, so it is oblique. If direct trauma, transverse. I think the last few topics is very important, very common, is Thomson test to know the integrity of the tendon just squeezing the muscle here. So squeezing the calf produce plantar flexion, plantar of the foot when the heel cord is intact. So the normal, if you squeeze the gastrocnemius muscle, so plantar flexion is occur, plantar. If not happened, so it is tendoachilles, squeezing, no movement, so it is tendoachilles injury. It is common in some European country because they have these people who dance what is called river dancer. River dance, it is the people who make a movement through the legs and the heel by special shoes. It's not common in most of the country, but common in Ireland. Okay. So it is important to know Thomson test. Of course, it is different than Hoffman test, what we do for deep venous thrombosis. It is just Hoffman test. You don't squeeze the muscle. You just dorsiflexion or plantar movement the leg, so the patient have pain in the calf muscle. We don't ask you about classification, but just I found this is a fracture involving epiphyseal plate. So what we called it Salters. So can be straight, can be above. This is Salter classification. Is epiphyseal plate. So it is just general classification is not important much. Just if we found it in some books. Last slide, I think this is the last two slides. The first one is about could fish vertebrae is in osteoporosis and sickle cell disease. So what we called it could fish vertebrae, like this picture. Okay. Could fish vertebrae. The last, is anyone know this is patient with multiple osteolytic secondary, what it could be? Anyone have an idea? This is common question. Sometimes it's the first question in exam.
Multiple myeloma.
Yeah, so this is multiple osteolytic secondary, so it is multiple myeloma. Multiple osteolytic secondary is common as X-ray, is multiple myeloma. Multiple myeloma is not important to know much about it, except it is have Bence-Johnson protein in the urine. It is diagnosed by plasma electrophoresis. It is due to light chain and characterized by M band in the plasma electrophoresis. Of course, it is important to know all secondaries except prostate is osteolytic secondaries. But if you have multiple secondaries, because it is difficult to have multiple secondaries due to any tumor, except multiple myeloma, because it is something in the bone marrow. Okay. This is the end for me today. Next time we speak about physiology, ECG, and ethics, which is also important topics. And if you have a time next Monday, so we have another exam, and you can take it for the Monday and Friday, one of the recall of previous exam. Okay, so it is important for, okay, thank you, I stop. So it is important